Welcome to the Seasoned Sonographer, the podcast where experience meets education in the world of OBGYN ultrasound. My name is Lynn Flamm, and I'll be your host. I'm a registered diagnostic medical sonographer with over 32 years of experience, most of that time in OBGYN ultrasound. Through this podcast, I'm here to share insights, tips, and case studies to help you sharpen your skills and optimize your scans. Whether you're just starting out or you're a seasoned pro, this is the place to grow your knowledge and confidence. Let's dive into today's episode. Welcome back to the Seasoned Sonographer. Today we're discussing umbilical artery Doppler and how it guides the evaluation and management of fetal growth restriction. This conversation is about more than measuring a waveform. It's about understanding placental physiology and fetal adaptation, and how our ultrasound findings influence real clinical decisions. I'm joined today by Dr. Danielle Tomevi, and together we're going to connect Doppler technique, fetal circulation, abnormal findings, and ACOG-based monitoring. Welcome, Dr. Tomevi.
Hello.
Hi. Let's start out with a little bio about yourself, your educational background, what you're doing now, and what inspired you to specialize in women's health.
Yeah. So I went to undergrad at Illinois State University, and then I went to medical school at University of Illinois at Peoria. And then I did my residency at University of Louisville. And then I said I was never coming back to Illinois. And then I got roped back in with a great group where I'm in a private practice. And I've been here now for 13 years.
How do you clinically define fetal growth restriction?
Yeah, so that's actually changed over the last few years. So we used to just say it was based on just estimated fetal weight. And over the last few years, we now say it's also can be based on abdominal circumference. And so if either one is less than the 10th percentile, so either the estimated fetal weight or the AC is less than the 10th percentile, it is considered fetal growth restriction.
And why do we also use the AC now instead of just that estimated fetal weight?
A lot you can see with the belly, also just in big babies. We use the AC to say large for gestational age as well. We know those diabetic babies store a lot of glucose in the liver and their bellies get bigger. And so that's come into play also describing growth restriction for using the AC as well.
Yeah. And how significant is an abdominal circumference below the 10th percentile when the overall estimated fetal weight is still over the 10th percentile?
Yeah, so I've actually talked to maternal fetal medicine about this, asking them, it kind of says gray area, total estimated fetal weight, yes, less than 10th percentile, your abdominal circumference, if that's less, but what happens if it's just abdominal circumference? Should it change your delivery timings like a total weight? And they are all going by AC as well to determine that delivery timing. They're saying the studies that is showing it's just the same.
And how do you differentiate constitutionally small fetuses versus a true placental insufficiency or fetal growth restriction?
I think it really comes down to when it's diagnosed. If you have somebody who's diagnosed with severe IUGR at anatomy scan, which we actually just had, you have to start looking for all the other causes. Was there what we call torch in the different infectious stuff? Is it genetic? This last one that we just had, it's genetic. Versus, developing later on that says that the placenta has just been stressed quite a bit and is acting differently.
What are the most common causes of fetal growth restriction that you see?
We'll see from either hypertension, different meds that people are on, medications, diabetes, longstanding diabetes.
And then do you find like some single umbilical artery, umbilimentous cord insertions also sometimes?
That's always a risk factor for it. Clinically, do we see that as a big cause? No, we see a lot of marginal cord insertions that don't lead to growth restriction.
So it's mainly those maternal morbidities, comorbidities that affect the growth. When do you suspect placental insufficiency versus fetal or genetic causes?
Yeah, I think it comes down to when you diagnose it. So at your anatomy scan, of course, if you have heart defects, renal defects, you're gonna have changes that are gonna affect amniotic fluid as well, and which can lead to growth restriction. Placental insufficiency is going to be, I feel, is later term, you're 28 weeks and above, when we start doing growth scans on hypertensives and diabetics or preeclamptics. We start them at 28 weeks and do them every 3 to 4 weeks. So that's when we're looking to see how the placenta is behaving, essentially.
Before we talk about abnormal Dopplers, I want to briefly review fetal circulation. The umbilical vein carries oxygenated blood from the placenta to the fetus. The two umbilical arteries carry deoxygenated blood from the fetus back to the placenta to be oxygenated again. In a normal pregnancy, the placenta functions as a low-resistance vascular bed, and because of that low resistance, the umbilical artery waveform shows continuous forward flow through that diastole. So when we see decreased diastolic flow, that suggests increased placental resistance. So when placental insufficiency develops, what is happening physiologically?
It's something within the vessels in that placenta. Usually they can have vasoconstriction, or they're just not as well developed.
And we use umbilical artery Doppler to assess that blood flow from the fetus to the placenta, and that waveform reflects how hard the fetus has to push that blood through the placenta. Why does diastolic flow decrease as placental resistance rises?
Because it's almost like a wall. So you're trying to hit a wall going through narrow vessels, and you're hitting this wall of resistance. And so it gets harder and harder to push the flow through it. And so that's what we're trying to measure and see. When is that placenta, when it starts to really not work well, doesn't allow the flow to go through an exchange of oxygen. That's what we're looking at, when that exchange of oxygen is no longer going to be able to happen because it's not flowing through.
And what does an elevated pulsatility index or resistive index represent clinically?
So when we look at pulsatility index, what it is calculating that variation in blood flow velocity between that systolic peak and that diastolic. So from the peak and the low relative to the mean velocity. And so you're using that one along with the resistive index, and that's a little bit different, where you go peak systolic and diastolic flow, and then you divide it by your peak systolic flow. So you're looking at that difference between your top and your bottom. And so when those get farther apart, you're going to have the higher numbers.
So it's also an indicator of early or mild placental insufficiency when that resistance is rising, right? And then the fetus has a great mechanism that protects itself by redistributing that blood to the brain, called the brain sparing effect. And we don't measure them in our general OB offices. That's a maternal fetal medicine specialty type of ultrasound, but it's measured by the middle cerebral artery Doppler, and the resistance decreases in the middle cerebral artery, allowing the blood to flow to the brain. At what point does Doppler abnormality become concerning enough to change the management?
Yes, so we actually measure, and we have different ranges for each gestational age. So it depends on, we use different tools such as perinatology.com, and we can put in what their gestational age is. It'll tell us where that 95th percentile is. And when it gets above the 95th percentile, we say it's elevated Dopplers. And then ACOG actually has it very well listed. You have to look at, we use not just the Dopplers, but also our non-stress tests as well, and movement in the point system with the biophysical profiles. We kind of use it all together. But if you just base it on, for instance, just growth restriction, and you have absent flow, okay, so you've got the wall, so we got absent flow, then that does change your delivery timings. That can be between 33 and 34 weeks, if we had diagnosed this much earlier. And then if we've got reversal flow, okay, the latest that they go is 30 to 32 weeks, but sometimes we don't diagnose these till later. So once we get that, the highly likelihood is they're going to recommend delivery.
So those Doppler deteriorations do influence delivery timing and decisions.
Mm-hmm.
What do you primarily rely on when assessing the severity of the placental insufficiency or
I think it's a
resistance?
combination of all of those. So the mom telling us how the baby's been moving. Moms have great intuition, and so you have to listen to them. Also taking into account how they look on our antenatal stress testing. Okay. Biophysical profile, how they're growing in between our growths. We don't like to do growth scans closer than 2 weeks. We like more 3 weeks. You have to put it all together. It's part of the whole picture together.
So you include the NSTs, the biophysical profiles, serial umbilical artery Dopplers, and we just talked about the ACOG recommendations.
And so those are our goals. So the ACOG, that's our goal to get to that.
Right.
But if things change before that, then we have shared decision with the patient.
Okay, so I want to review technique for sonographers. From a sonographer perspective, technique matters because management decisions rely on these numbers. The umbilical artery Doppler is clinically valid after 24 weeks gestation. In order to perform the umbilical artery Doppler, you want to identify the 3-vessel cord and the arteries using the color Doppler. And then you would drop that pulse wave Doppler gate into that umbilical artery. You want to sample a free lip of cord, no fetal breathing and no movement, away from the fetal cord insertions at the abdomen and at the placenta. You want to maintain an angle of insonation at less than 30 to 60 degrees for that Doppler sample. Obtain at least 3 consistent waveforms. Measure the SD ratio, the pulsatility index, and the resistive index, and be sure to document the absence or reversal of end-diastolic flow. When placental insufficiency develops, when would you like a sonographer to add the umbilical artery Doppler to a study?
If we have growth restriction.
Okay.
Outside of that, it's hard to say what to use it for. Okay. If you have normal growth and somebody just does a Doppler, you don't know why, and it happens. Sometimes people do them. And then you get this abnormal Doppler, and then we have to call maternal fetal medicine, like, well, I don't know what to do with that. Let's repeat this at a different time.
Yeah.
So where it's most indicated, where we only should be doing it, is for these babies when we have growth restriction. So our sonographers in our office will say, hey, growth restriction was less than the 10th percentile for total or abcirc. I went ahead and did the Dopplers and I added the BPP. We already have a system in our office that they just go ahead and do it.
How important is Doppler quality and reproducibility in that decision making? You talked about how you really rely on your sonographers. You know they're performing them correctly. So really that is...
Yeah, I mean, you have to have a trust with your sonographers, and we do look at their scans, and just like your office, we have great sonographers too. So we trust them. And so when they tell me something's off, I really start looking at those images.
Yeah. And what do you wish sonographers better understood about how Dopplers impact management?
I think if you're not comfortable with your technique, you got to learn and get there, because our deliveries do depend on it.
Poor technique can lead to misinterpretation, and misinterpretation can change the management.
Mm-hmm.
How do you counsel patients when these Dopplers become abnormal?
Yeah, so it's a long conversation because lots of questions come out of it. There's a lot of discussion on risk-benefit ratio, and I talk about that all the time in pregnancy, whether it's diagnosis of hypertension when you're inducing or anything like that. It's always risk-benefit ratio. And there's lots of studies on this area of when we deliver. So we know that there's something with the placenta. A lot of women who have growth restriction think if they just eat more, the baby will get bigger. And you have to kind of tell them that's not going to work. It
works. Yeah.
There's something with that placenta. And at some point, we're watching baby very closely. I want you looking at your kick counts. If we're not hitting that, I want you coming in. We're going to do additional monitoring. And we're trying to get to where our goal gestational age is. And it's always going to be discussions back and forth, but it's nothing that you did. It just is. Every day is 48 hours less in NICU, and so we're trying to find when is it better to be out versus in.
Right. It's that prematurity risk versus the placental insufficiency risks. Okay, if you could give sonographers one key message about umbilical artery Doppler in fetal growth restriction, what would it be?
It's just get comfortable with the technique.
Learn the technique, do it right, because it does change management. And the goal is early detection of fetuses who are not getting enough oxygen and nutrients due to poor placental function. Mm-hmm. Well, that's it.
Okay.
Thank you so much for joining me for this episode of The Seasoned Sonographer. If you're interested in improving your OBGYN ultrasound skills and learning more about the field, make sure to subscribe to The Seasoned Sonographer on Apple Podcasts, Spotify, and YouTube. You don't want to miss any of the upcoming episodes. You can also connect with me on Facebook and Instagram at Sono Techniques Academy. Explore more educational resources on the Sono Techniques Academy app or reach out via email, lynn@sonotechniquesacademy.com. I'd love to hear from you. If you have questions or topics you'd like for me to cover, feel free to reach out. This podcast is for you, and I want to make sure I'm covering the topics that matter most to you and to the ultrasound community. Until next time, keep striving for excellence in your scans, and I'll see you in the next episode of The Seasoned Sonographer. The information provided in this podcast and any accompanying materials is for educational and informational purposes only. It is not intended as a substitute for professional medical advice.